Wasangan Akiyemi. He received his Bachelor of Medicine and Bachelor of Surgery from Nigeria, and he completed a residency in OBGYN, becoming a fellow of Nigerian postgraduate medical college in 2017. He subsequently completed a Master of Science in Public Health from Western Illinois University and currently a Senior Research Associate at the Department of Surgery Outcomes Research Center, Howard University College of Medicine.
Thank you, everyone. Thank you for the opportunity to present findings from our study. My name is Akiyemi. We have no disclosures. Since its passage in 2010, the Patient Protection and Affordable Care Act has improved healthcare access for minorities and socioeconomically disadvantaged groups in the United States. The expansion of Medicaid eligibility has remained a key factor in promoting health equity. And in fact, there has been more than 20 million previously uninsured Americans that have gained access to healthcare coverage following the implementation of this policy. As at 2024, most states in the United States have implemented the Affordable Care Act policy, with only 10 states, primarily states in the South, yet to adopt the policy. In the present study, our objective is to assess the impact of the Affordable Care Act on outcomes of Black women with breast cancer. Specifically, our aim is to compare cancer-specific survival and disease stage at presentation between Black women residing in New Jersey, where the ACA was implemented in 2014, and their counterparts in Georgia. We utilize the SEER registry to perform a retrospective analysis so as to compare breast cancer outcomes between Black women in New Jersey and their counterpart in Georgia. We utilize a difference in difference methodology to assess this impact. The study covered 2 time periods: the pre-ACA period, which we define as the time between 2007 to 2013, and the post-ACA period, which we define as the time between 2014 and 2020. We chose Georgia and New Jersey for comparison due to their different ACA implementation status. Because Georgia implemented the policy in 2014, and as at now, New Jersey implemented the policy in 2014, and as at now, Georgia is yet to implement the policy. However, despite different economic status of these different 2 states, with the shared case indices that are crucial for cancer screening, and these indices include the population age 18 to 64 years, which is almost similar, cancer rates, which is the same, breast cancer screening rate, which is also very similar, though they have different uninsured rates. Also, our options are also limited when comparing states that utilize the Affordable Care Act to states that are yet to implement this state, because we have less than just 10 states in the United States now that are yet to implement the policy. New Jersey implemented the Affordable Care Act in 2014, under which Medicaid was referred to locally as the New Jersey Family Care. This expansion allows adults aged 19 to 64 years with incomes up to 138% of the federal poverty level to qualify for Medicaid. Since the implementation of the Affordable Care Act in New Jersey, Medicaid enrollment has significantly surged by 78%, reaching nearly 1 million residents between 2013 and 2023. Notably, New Jersey does not impose work requirements as a condition for Medicaid eligibility. In contrast, Georgia did not adopt the Affordable Care Act but instead secured a waiver to offer health coverage to a subset of low-income individuals. The Georgia Pathway to Coverage program provides government health insurance to individuals earning up to the federal poverty level. However, Georgia imposed a condition to the Georgia Pathway for Coverage, and this condition includes verification of employment, schooling, or other qualifying activities. Additionally, the work requirement verification was mandated as part of the eligibility criteria for Medicaid benefits in Georgia. Looking at these two different states, our hypothesis initially at the beginning of the study was that since New Jersey implemented the policy and Georgia did not implement the policy, we believe that outcomes most likely will be better in New Jersey when we compare to Georgia. So I will give you what we have, a breakdown of our results. Black women with breast cancer constitute 20% of the total population, of this total study population, and these are our major focus in this study. Post-ACA, the proportion of black women receiving care in Georgia slightly increased, only from 28.4% to about 30.1%, as we can see in the figure. We also have a similar marginal increase in New Jersey, rising from only 11.9% pre-ACA to 12.5% post-ACA, despite the implementation of this policy. Among these black women with breast cancer, surgical intervention rates remained relatively stable in Georgia, shifting slightly from 87.3% in the pre-ACA period to about 87.9% in the post-ACA period. In contrast, in New Jersey experienced a decline from 88.9% pre-ACA to 85.1% in the post-ACA period. Chemotherapy utilization was also 54.2% pre-ACA in Georgia and 52.3% post-ACA. In New Jersey, it was 47.2% pre-ACA to 46.7% post-ACA. For radiation therapy, these are the three major treatment modalities for breast cancer. For radiation therapy usage in Georgia, it increased from 50% pre-ACA to about 52.3% post-ACA, while in New Jersey, it rose from 39.4 pre-ACA to 47.3 post-ACA. That was a significant increase. In both states, however, the proportion of women receiving care who earn less than $70,000 per year decreased post-ACA from 91.2% to 78.8% in Georgia and from 49.7% to 44.9% in New Jersey. A focus on the disease stage at presentation, we observed a significant increase in early stage disease presentation, which is what we expected and we hope for. That is the major aim of the Affordable Care Act. However, this improvement was also noticed across the two states. In Georgia, early stage presentation rose from 36.1% pre-ACA to 47.4% post-ACA. And in New Jersey, it increased from 35.8% to 47.1%. Concurrently, there was a notable decrease in stage 2 and stage 3 disease presentation, alongside a slight increase in stage 4 presentations in both states. We went ahead to conduct a cost regression analysis and draw these forest plots, which illustrates the hazard of death, which is also indicative of cancer-specific survival. We adjusted for baseline characteristics, disease stage at presentation, treatment modalities, income, and whether these women live in rural or metropolitan areas. The vertical line in the graph serves as a reference point. When the variable moves to the right of this line, it indicates a higher hazard of death and poorer survival, whereas those to the left suggest a lower hazard and better survival. We notice that the graph reveals that black women have a a significantly higher overall hazard of death. That's worse survival across when we look at the different race and ethnicities. Although the post-ACA period is associated with improved overall survival, which we have seen earlier, the interaction analysis shows that there is no significant difference between New Jersey and Georgia in the post-implementation, in the post-ACA period. We went ahead to generate a margin plot to further clarify the result of our interaction term analysis, comparing the predicted probabilities of early disease presentation across both states and time period. Notably, Georgia experienced a significant increase in early disease state presentation, rising from 48% to 58%, a 10 percentage point, and in the post-ACA period. Similarly, New Jersey also experienced a significant increase from 45.8% to 57.7%, a marginally different, a 12 percentage point increase, slightly higher than that of Georgia. Interestingly, the predicted probabilities of stage 4 disease presentation show a slight increase in both Georgia and New Jersey, increasing in both states in the same time period. The implication of our study findings are significant for healthcare and policy. It appears that Black women may not be reaping the anticipated benefits of the Affordable Care Act implementation in New Jersey, because we expected that the results that we are getting from New Jersey should be significantly better than what we are having in Georgia. Similarly, it may be that Georgia state policy, which may replicate some effect of Medicaid expansion, might be yielding comparable outcomes. Additionally, the follow-up period post-ACA may have been too short to detect significant differences in breast cancer outcomes, given the long-term nature of the disease. Furthermore, improvement in survival and early disease presentation, coupled with a decline in late disease state presentation, may reflect overall advancement in breast cancer care rather than the direct effect of the ACA. This will explain why such improvements were observed in both states during the post-ACA period. In conclusion, we observed significant improvement in breast cancer outcomes among Black women in both states following the ACA implementation. However, there were no clinically significant differences between these states during the post-ACA period. Thank you. I'll be happy to answer your questions.
Thank you, everyone. We have a microphone there, so if anyone